All right, let's go ahead and get started. And again, welcome back. A lot of familiar faces from yesterday. And this, what we call the Military Health System track here at AMSUS is going to continue with, again, the same theme that we had yesterday. And you're sitting in my seat. So anyway, just kidding. Just kidding. So basically, what we're doing is we're taking Dr. Woodson's 6 lines of effort, okay, and we're using examples to expound on those, and then kind of what I call going big to small. And so one of the things that we wanted to talk about was, which has been looking at the organization and do we have the right mix. An ongoing effort. It's called the Medical Modernization, of which Dave Smith and Al Hamilton have been an integral part of that. And so we thought it would be a great opportunity for you to understand, because all you're doing is sitting out there in the hinterland saying, what do you mean Dr. Smith wants to close my inpatient facility? You know, by God, you know, what's he talking about? You know, and so, well, now we want you to understand and the why, you know, why with a finite amount of resources, you know, is as we put it here real simple, matching the requirements to the demand signal. There's a finite amount of resources, so you got to match them to the demand signal. And so Dave's going to tell you about that journey that we are on right now.
Well, thank you, General Robb. Appreciate the kind introduction.
Yes. These are all people want to know why you want to close their hospital.
Absolutely. So hopefully we'll be able to give you a good overview of this project. And I have to say I'm extremely excited, although biased, because I've been ensconced in it for 2 years, but with what has been developed to look at, and what this is the line of effort that's basically about defining medical capabilities and manpower for the 21st century. And being the readiness guy, I will tell you bottom line that this is all about making sure that the military health system is actually positioned for the future to maintain a ready medical force. Because if you think about it, there's one reason why the direct care system really exists, and the primary reason why it exists is for maintaining a ready medical force and a force that's medically ready. We have a military health system which has both a direct care and a purchase care system that critically is taking care of our 9.6 million beneficiaries, and they have to be taken care of. But the venue of where they're taken care of can be agnostic, but we clearly know we have to have the direct care system to be able to maintain that ready medical force until a genius comes up with another more effective way to do that work. And so that's what we want to go through, because we've done now the first round of analytics over the last couple of years to try to answer and provide tools to be able to manage us in the future with that. Now, the other caveat I'll make is that you'll be disappointed if you're coming here to hear all of the solutions that have come out of this work, because that's still internally being debated in the department. We're getting very close to a set of final decisions. The NDAA actually requires us to generate the report out of this and report it to Congress, but that has not gone through all of its clearances, so I will not be talking about, I have some specifics, but not specific locations or changes or those kinds of things in the report. So you can leave now if I've totally disappointed you and you don't want to hear the rest of it. But
if they ask a question, one finger's yes, 2 fingers no.
And since I don't have a very good poker face, I'm sure you can sort of suss out what the answer is, perhaps. But with that, medical modernization. So let me see if I can figure this out. And so this all started with a Resource Management Directive, as they're called, an RMD in the department, which basically directs us to do something coming from either the secretary or the deputy secretary. And this is actually what they requested us to do. And it was to essentially do what I just said, which is to look at the system and make sure that we are positioned, if you will, for the future, specifically in the areas of personnel, infrastructure, business processes to make sure that we have the best practices for increasing our effectiveness, that readiness, that being able to do the mission that we've been called to do, and also look for efficiencies. But I will also tell you that this is, in my mind, primarily, and the reason why the readiness guy is running this is it's about that readiness piece. The good news is we've actually found some efficiencies potentially in it also. But that's sort of a secondary piece of this. And I would argue that because of that readiness mission, if we have to cost more to do that in some situations, that's perfectly defensible because it's part of the mission, if you will. What's not defensible is if we're costing more doing stuff that's not contributing to that readiness mission. And so that's the message that you'll hear over and over during this. So we also know we have a lot to be proud of. Over the last going on 13 years, we have clearly developed the world's best trauma system with highly skilled patient support system all the way from the point of injury all the way through rehabilitation in this system. And so we clearly want to be able to build on that and continue that as the contingency operations begin to drop off. Although with the world somewhat on fire, who knows how much of that will be, but we clearly recognize that we need the ability to be able to maintain that edge that we have developed over the last 14 years. And we also have shown that we can clearly leverage our purchase care system and our direct care system to be able to accomplish that. Now, Mark helped me analytically come up with some of the facts that help talk to us about this case for change. The first one is that our average inpatient facility is 35 years old. Now, that's actually dramatically better than what it was 5 years ago when it was averaging around 50. So we're actually in reasonably good shape. But what we also know is that we have about a 23% utilization rate of the inpatient capacity. And a lot of that is because medicine has changed. And clearly we know that much more and higher acuity and complex cases are being done in an outpatient manner than they clearly were 10 years ago and clearly 20 years ago. And that's been part of it. We also know that our populations have been changing. The services have been changing in size and moving around. And so we need to make sure, and part of the point of the study is making sure that our facilities are matched with where the populations are of the patients. Another issue is we realize that many of our patients don't necessarily choose the direct care system. As it says, 37% of our enrollees in our 5 largest markets are not using the MTF. Now, part of that is choice. Part of that is that we may not be staffed to be able to accommodate, and so we've had to send them out onto the market. And then finally, we know that the costs are continuing to rise, and so if we can find efficiencies and make sure that we are orienting them to the message that I've been putting across of a ready medical force and a force that's medically ready, there may be savings to harvest. So here were the study parameters, and we had a couple of premises. The first one is that we know that we, as I demonstrated in the last slide, have some legacy processes that we have to staff. So we have some relatively large inpatient facilities that do not have the patient population to support them. We have places where we have large populations of beneficiaries, but we don't necessarily have adequate capacity to take care of those folks. And the other one is that we need, and the premise we made is that clinicians need to be busy, and clinicians need to be located where the work is that will maintain their clinical readiness. And so if we take that and as our premise, then we had some principles, though, that we knew that were just absolutely bedrock for the MHS. And the first one, of course, is to maintain and enhance the access and quality of care for all of our beneficiaries. So we couldn't do anything that was going to adversely affect the ability to actually get high quality care. We also know that we need to focus on the readiness of the uniformed force. As I've said over and over, the ready medical force and the force that's medically ready. We also wanted the study to be transparent, to have the involvement of all the players in this. And so in our study, we've clearly had very active service representation. We've also had analytic representation from the department to make sure that everybody understands, and together we create the models that we all can use to look at the subject. We also wanted it to be data-driven, to not be based just on this is the way we've always done it, or subjective feelings, but also recognizing that some of the areas are going to be hard to quantitate, but we need to make sure that we are positioned to take care of the mission that we've been given to provide. And then one of the requirements of the RMD was that we came up with recommendations for the POM, the Program Objective Memorandum, which is our budgeting cycle over 5-year periods of time. So the study, as I mentioned, we've been doing this for about 2 years. It started out as a one RMD that said to do what we talked about in the beginning, and we went through that and concentrated primarily on our inpatient hospital facilities, because we knew that that is where, particularly for the specialty side of the enterprise, that they got their readiness skills maintained and honed. And it's also tends to be the high cost areas, and as I mentioned earlier, that's also where we appear to have a fair amount of unused capacity. Well, the comptroller was so impressed with what the group did the first year, they issued another RMD and said, well, that's not adequate, just looking at the what really turned out to be the smaller inpatient facilities. We want you to look at all facilities in the entire enterprise. So that extended our life, and that's what we've done over the last year. Another couple of points on the slide that are important to understand as we're going through this are that we now have the enhanced or empowered multi-service markets. Well, when you start actually doing our analysis, as you'll see down the way, it's very hard to parse out, if I'm talking about an individual beneficiary, of whether they're going to go to one services facility or another services facility if they're in overlapping catchment areas. So when it comes to the MSMs, we treated them as one market rather than trying to decide that, let's say it's an Army and a Navy market, that who's going to go to the Army side and who's going to the Navy side. So you need to understand that when you start seeing some of the results. Another piece of it is you clearly, when you're doing this kind of work, need to be able to recognize that we have slightly varying populations, more active duty, more retirees, whatever the case may be in our various markets. And so to try to normalize that, we have put granularity into the analysis to be able to tell how many females over the age of 65 are eligible in a particular area, or how many males under the age, pediatric, under the age of 18 are in a particular area. How many are active duty, how many are active duty beneficiaries, dividing them up to help give an idea of what the workload and the variety is in a particular population. We've evaluated each of the specialty lines, as we'll discuss, and then finally, we went through a process of figuring out, well, what is the mission? And clearly, we recognized that we needed to maintain outpatient care for both our active duty and our family members of active duty anywhere we are already providing that care. And so if it was an active duty only facility, clearly it would probably stay that way unless it made sense to expand it. But in any case where there's already both populations being treated, we would assume that that capability would be maintained no matter where we were. So there were also some assumptions that we made. We made the assumption that, as I think we all know, that the military health system provides quality and safe care. So we did not directly address that issue in this or use that as one of our factors when we were looking at the facilities. And I think the MHS review that Dr. Woodson talked about yesterday sort of exonerated us, if you will, about that assumption, because we made that assumption well before the review was made, knowing that we were going to have that we had a quality system. We also made an assumption about the fact that keeping providers busy was a great way to maintain their readiness. And we'll talk about the whole issue of currency and what's going on with that in a little while. But we also primarily, the analysis is primarily provider-centric, with the assumption that if the provider is busy and there are enough cases for that particular specialty, then the team will also be kept current and having the exposure that they need to be a ready medical force. All of these assumptions, can be debated, but I think on balance, was a reasonable assumption also that we made. And we also made the assumption that the MHS can recapture patients. That when we've got a large patient population, because of the quality that we offer, because of the customer service that we can offer, we would be able to recapture patients. Recognizing that they're already enrolled to the managed care support contractor, that's an easy day. We can get them into our prime program. We also assume that some of the standards, but we weren't as aggressive as what we thought the recapture could be for that. And then we knew that we could recapture some of the over 65s, recognizing some of the financial ramifications of increasing our over 65 population, but also recognizing how important they are to our enterprise. So this is the basic design of the study, and I'll start with the center block. The first thing you need to know when you're trying to figure out how can I maintain a ready medical force is how big does that force need to be? And so a central part of this was going through and doing that analysis that we'll talk about. Another piece that I glanced upon earlier is trying to figure out what are the requirements then to keep that force medically ready, and that's in the lower left-hand corner. And then another question is well, what's the demand possible, both what is the demand now and what is the potential demand in a particular market, and that's in the right lower box. And then you put all three of those together to look at how do I allocate my manpower to optimize the readiness. So let's go through each of those in a little more detail. After I explained to you, we broke up into various analysis groups to cover those 4 areas that I mentioned. And then we started putting that all together, and Mark will talk about that in a minute. The services then would help us evaluate some of the other variables that doesn't cover. For example, some of the important things like what is the mission requirement? And what's the local healthcare environment about? There may be places where, well, gosh, there isn't a facility within 50 miles. So we clearly can't consider not having our own facility here. That's why we're here. Clearly, it's an obvious reason. So the services helped figure those pieces out. Or another question would be, okay, if I'm going to change, can the local providers actually take up the load that we've been basically taking care of for them? Very critical piece of this also. And so the services, along with the TRICARE area office, was able to help us with that. And then finally, that went through the governance process to the ultimate executive board, if you will, for the military health system, which is the Military Health System Executive Review, which the Undersecretary for P&R with Dr. Woodson chair, with the Surgeon Generals along with the vices of the services. So the 4 vice chiefs, along with Thank you, manpower and reserve affairs folks from each of the services. So those folks were the ones then that ultimately look at and vet the requirements. And if there was disagreement at that level, then it would be bumped up to the secretarial level. Okay, so on the uniformed force approach, we basically used what the department uses as its scenarios for planning purposes, and they have they periodically re-review and say, we're going to need to be able to fight in the worst case scenario, something that's going on here and something else that's going on here, and then you need to think about this also. And all of those actual scenarios are classified, but all the services along with the department do their analysis to figure out the sizing of the ultimate services based on those scenarios. So we took those, and through the joint staff and their development process, there are now tools that are able to, taking those scenarios from a medical planning point of view, figure out what the requirement is for personnel to be able to successfully execute the various pieces of those missions. That then gives us the total medical manpower required for whatever that worst case scenario is that the department is planning on. And then we gave those pieces to the services to say, here's the Air Force piece, the Navy piece, and the Army piece. Run those through your algorithms and tell us how many people you need to be able to then have, you can't be at war the entire time. You got to have some time back in garrison, right? Or back on shore. And so there's a whole series of support folks and sustainment folks that then raise the number of folks that we have. And that ends up with, we have the deployed requirement, and then we have the total uniformed requirement. But then there's budget reality. And so each of the services take some risk and say, okay, I realize you need X number, but I'm going to give you X minus this number, and that's what I'm willing to pay for. Or X plus in some cases. And so we took whatever they're willing to pay for as the assumption that that was how many uniformed providers we would expect to have, and that's the authorized force. I recognize the uniform force may be slightly different than that because we weren't able to recruit this or that, or we recruited more than we needed in a particular area. But the authorized force, what the budget is ultimately authorized to pay for, makes a reasonable assumption on these need to be in uniform, and we need to be able to keep them current, ready to deploy. So that's the first piece of the equation, and we accomplished that piece. I'm going to skip this one and come back. The second piece that was done, our subgroup looked at clinical currency. And they did a review of the literature, looked at what each one of the services were doing to try to come up with what makes sense. We also looked at all the professional organizations, and there's very rigorous requirements for what is required to get you to certification. Where it gets very sort of squishy and not well defined then is what it requires to maintain the certification, other than for docs, going back for recertification of their boards on a periodic basis. I need a certain number of CMEs for my licensure, but how many procedures I need of this and how many I need to do of that, et cetera, there really isn't an obvious set of standards. All the services have been working on this for a long time. I will pro-offer that my personal opinion that the Air Force is the furthest ahead in this, but we have a group now recognizing how important this is that's working this issue for the whole military health system under the Medical Operations Group, the MOG. because we had to punt on this, essentially, to be frank, because we couldn't come to, and there was no obvious, in the time frame we had, agreement as to what that was. So we picked the closest surrogate that we felt was appropriate, which was productivity. Because, and the rationale was, if I'm productive, if I'm very busy in my clinic, most likely I'm maintaining reasonable currency, and it should be a reasonable model for that. So, so the conclusion is that we used productivity, and I will say we want to do better than that, and we need to do better than that. But that's what we got right at the moment. So productivity was the measure that we used. So we also recognize that if you're in uniform, there are a number of things that are required for your military readiness that are different than if I wasn't in uniform. There's also the fact that there are different leaves, different other pieces of it. And so we had a group, the same group, start deducting from the amount of time I would be available in clinic based on all of the sort of military requirements we could come up with. And you know, there's also the GMT, the general military training, all those pieces that came through. And the answer basically by specialty, and it varied because obviously some like trauma surgeons need to go to trauma facilities to recertify on their skills. You can see by specialty it might vary some, but it ranged from a low of about 72% of the time available to a high of around 80% of the time available. The other thing the group did was they looked at, okay, well, are there any standards out there? And it turns out there's an organization called the Medical Group Management Association, MGMA, which I'll refer to from now on, that actually does a poll on an annual basis and comes up with what is a reasonable number of RVUs, relative value units, by specialty, both in academic environments and in a non-academic environment by specialty. And so we figured that's a reasonable surrogate for us, and they give a median level across the United States. And we would take that, and then you can multiply it by 75.7 or whatever your specialties is, and that would give a relative target. The reality was when we looked, and we have, as everybody knows, MEPRS is continually improving. What we found out is that our productivity is substantially less than what that calculated value was. And so one of the conclusions has been that we need to work on that and set some goals relative to that. So that's the currency piece. And then I'll go back to the healthcare demand approach was the third component. And on that component, it's looking at, here is Fort X and Naval Hospital Y, or Air Force Unit Z, drawing the catchment area around it, how many beneficiaries are there out there? And what is the demand signal, if you will, of those beneficiaries, both within the direct care system and the purchase care system, to give us an idea of what is possible in that particular market. Because there are clearly some markets that are much bigger than others, and so that will determine how you would staff relative to those facilities. So using those 14 cohorts and an enormous amount of analytic brain power and machine power, they were able to develop this into a analytic capability that we can tell by market what we think the demand signal is. And then we also know about what population is required to maintain a specialist. And so those are the three components, and I think I will now pass over to Mark Hamilton to talk about how we put those all together as the main analyst in this project. So Mark.
Okay. Well, let me see if I can get the right thing here. There. Okay. We did all this work, and frankly, this is at least half a year's to 3/4 of a year's worth of work just to do this, because of the numbers of different factors that we've never even looked at before, that we had to work through as a team to come up with some standardized way to approach it. I want to say from an analytical perspective that this is one of the hardest projects that I think we've done in the MHS, given the scope of what we're trying to do and the sensitivity of it. So we took all that information and we turned it into a model, which we call the provider allocation model. And in the process, what we did was very straightforward. How much is there out there in the market that is available? And this would include everybody, not just the people who come in our doors, but the people who are not coming in our doors. And then we try to allocate that by cohort, like you said, and adjust for unique demand signals. For example, students, they're not enrolled, so we had to find out what that was. In addition, we also have people who come to us who are reimbursables, and those types of people who come in from the State Department and from Dodd schools and from other places. We had to take care of all of that. Some of it was in the data sets and some of it was not, but we went through that. Then we had to determine the number of providers supported at the various levels of productivity, because remember, we haven't set a standard yet at this point, so we were trying to do some sensitivity analysis. And then finally, once we had gone through all that and set up the basic model, we run it. And then what we get are different options for allocating providers and their staff across the MHS. And clearly we're looking at this at an MTF or market by market basis to see where things are, and we can find out where they're stationed now, and we can see what the differences are and come up with some recommendations. Okay, clearly what I want to say is here is important is we looked at everything in the MHS. We looked at primary care. We looked at surgeons, we looked at orthopods, we looked at everything we could find. There were a couple of specialties where it was more challenging. One of them was anesthesia, because it's hard to find the workload on an anesthesiologist because it's not consistently entered into the database. So that's an issue that has to be resolved. But we know that if you're doing a lot of surgery in a place, you're probably keeping an anesthesiologist pretty busy. Again, we did a sensitivity analysis. This wasn't about taking a point on the wall, throwing a dart and saying that's the answer. Really did look at what this means, and here's why. There's a mathematical relationship here between staffing, productivity, and this standard. So the higher the standard I make, the fewer number of physicians or providers I can keep busy in the system. So you want to calibrate that as best you can, given the fact that what we found when we looked early on in the actual currency area, as you saw, that the actual level of production from our uniform staff, remember it's about the uniform staff, was not nearly as high as we had anticipated. So we wanted to make sure that we didn't build something in that was unachievable for the MHS. And there was a lot of work done around that. And then that ultimately set some quantitative targets for productivity. Everybody's heard about it, by market, by specialty. So how did this work? Again, how did we actually do the recapture? I think this is important because it was complicated by the fact that we've been trying to do recapture. I was in the Air Force for 27 years, and I've been doing this for nearly 15. So I've been in the MHS a very long time, and all of that time we've tried to do recapture. And to be honest about it, it's had relatively indifferent results. And so the question is can we set a recapture target for a market that's actually achievable? Remember, we have 14 cohorts, so we can actually do recapture by each of those. So what we came up with was a kind of a novel approach to doing this, which is take the best market in the country, MHS, that has the highest market penetration in surgery. It has a penetration of, let's say, 60% of their market share in a particular category, like let's say retirees, male retirees under 65. 60%. Take what you have in your market in that same category, let's say it's 40%. Take the difference and take 30% of that difference and then add it back to your 40%. So what you end up with is rather than having to recapture to 60%, you have to recapture to 46%. So it's a 6% change, not a 20% change. We, in the discussions of the team, the feeling was that this is part of the reason why recapture may be so difficult, is because we set very large goals to get to. So we need to calibrate this a little differently. And we went in and we actually made some assumptions, which I'm not going to talk about here, about what the opportunity for recapture is in over 65s and under 65s and these people and those people. And so we calibrated it so we could make it as easy as possible to reach these goals. The 30% was chosen as a part of the sensitivity analysis, which I won't go into in great detail here, but it wasn't just picked out of the air. Okay. Productivity goals. Again, a part of the sensitivity analysis, what we found was that productivity is a highly sensitive factor in this model. In other words, changing market share does change how many providers you can put in a location, but changing the productivity of those providers, what you expect out of them, is actually way more sensitive. And so it was very clear when you looked at the sensitivity charts that the calibration of the productivity is the key factor in terms of being able to think about optimizing provider opportunities for maintaining their clinical skills and their teams. Okay. In the end, like it says here, we increased productivity against the providers supported and recapture needed, and what that means is we did the sensitivity analysis and sat around in a room for at least 3 or 4 hours trying to think about what it means to go in these different directions. In particular, what we came up with was 40% of the MGMA median, which I'm sure everybody in this room has heard about, as the target for each of the provider specialties. Remember, it's linked against the MGMA median, right? And so the question would be, is 40% of the 50th percentile doesn't seem like a very big stretch goal. However, there's a lot that has to go on in here, and you have to go get more market share to do it. And again, there's this mathematical relationship between what this number is, what you think you can get out of the market, and how many people you can actually deal with. And we'll talk about what happened in that equation in the next slide. I think it's the next slide. Yes. When you do this and you pick 30 and 40, what you find out is that based on the number of uniform providers that we think we say we need in the MHS, as Dr. Smith mentioned, there's not, in many cases, there may not be enough available workload in our system, and I'm talking about our people, our beneficiaries, not our hospitals or our clinics, to maintain 40% of the MGMA for all of the providers that we have. Okay, what this tells us, and I think this is something that everybody kind of knows, but we've quantified it for the first time here and tried to put a number around it. There's plenty of debate about these numbers. There's plenty of debates about all different parts of this, but the model says that in some of these cases we're going to find that we just don't have enough workload. And it's interesting because it tends to be in those specialties where we have our highest readiness concentration, if you think about it. CT surgery, cardiovascular, cardiology, neurosurgery. It's interesting when you talk about the general surgeons because it's gone back and forth in the model on whether we have enough or not. But right now we have enough workload in our system to maintain 40% of the MGMA for all our general surgeons, but that's 211 that are authorized. We could probably place about 225 in our system. So we're right on the margin for general surgeons about being able to maintain that 40% of the MGMA. Not surprisingly, what we call, at least what I call the family practice group, is well represented. We have no problem getting primary care, OB, internal medicine, or pediatrics. Now I'm talking about general internal medicine. Specialty internal medicine is a different issue. We have no problem dealing with that, and it was very clear in the model when you looked at it because, for example, in the family practice area, we could put all of our uniform family practice docs in our top 5 or 6 multi-service markets, and they'd all be taken care of, have plenty of workload, but I need family practice docs in the entire rest of the MHS. So we have a large family practice group that includes a lot of civilians and contractors for a reason, because we have the workload, we need it. These are absolutely the people that provide much of the care that keeps the force medically ready. So, okay. Again, some of the findings, we have more than enough workload to support PCMs. Right now, the average enrollment is about 989, and we're proposing that the services work towards the 1,100 to 1. And then if the services do redistribute any of the PCMs, that they emphasize the markets where we have hospitals and specialty care, because that's actually the entree point for us. Now, we also looked at, and I don't have a slide here on it, but we also looked at, if you go to a PCM, either at the MTF or in the market, where are you likely to be referred? Most people in here will understand that if you go to a downtown doc for your primary care, he's going to refer you to his guys somewhere else in the system, and that shows up in the data. So we think that an option for the MHS to consider is that we should be using our own PCMs. Certainly we have to robust up the interface with the contractor, but using our own PCMs in big markets like this one to help direct people into our MTFs, to give us the kind of opportunities we need to keep each one of the uniform providers in this room at somewhere close to the upper level of your license, so that you can be ready to go downrange at a moment's notice as time goes by. The overseas hospitals, we looked in the same manner as the overseas hospitals and discovered that there's certainly a number of different issues over there that are very different from what we see over here. For one thing, and I'll get to the middle here, family costs and separation at mom's stork nest. Much of what goes on overseas is OB, and so what we're talking about here is what do we do with that? And if we do send it downtown, or we stork nest the mom someplace else, there's all kinds of family issues that come with that, and so that's one of the risks that we looked at. We have to sustain surgical capabilities at the theater level. In Korea and in Europe, you have to have some kind of surgical capability to be deployed out of there, because those are direct deployment missions. There's also some issues that we discovered relative to what I call including warning and reconstitution times. In some cases, you may have very short warning times before the bad guys are coming across the border. And in other cases, you may find that the current war plans are looking at medical reconstitution, which is follow-on forces, after an extended time. So it's sort of a come-as-you-are sort of position, and you're stuck with it for at least several weeks or more. And so how do you handle that? So we took all of this and sort of mixed it together for the Pacific and for the Europe. Lastly, from a clinical perspective, or at least a healthcare perspective, there are barriers. I mean, language is obviously a barrier. There's the nursing practice, bedside clinical practice barriers. They do, in Italy, they do pain medicine for moms differently than what we do in the States. You may have to, there are no bedside nursing. They don't do bedpans. You have to do that yourself. So there's some of those issues you have to deal with. And in some cases, there is a reluctance on the part of the host nation providers to do routine care of American patients. They always do emergency care, no problem with that, but sometimes they just are not as excited about doing the routine care. So we did go through this and made recommendations for the Pacific and the European theater, and we are in the middle of discussing that with the Deputy Secretary and the Chiefs of Staff and the Secretaries and everybody on the E-ring of the third floor and subsequent floors at the Pentagon. We're expecting a decision on that in the first of the year. So sorry about that. Okay. Les, did you want to do this, or that's up to me? Okay.
It doesn't matter.
Okay.
So that, that sort of reviews all the components of the study. We clearly have found, and there are recommendations out about some, the need for reallocation of some of the specialties, that we have some inpatient facilities that don't warrant continuation as inpatient facilities. We have some facilities that need to be expanded. There's clearly the 30% and 40% that we talked about, where we're the MHS has now set the goal to get productivity at a minimum of 40%. Folks that are already at that are expected to continue to improve their productivity, and also commensurately to try to recapture all of the enrollees that are out in the private sector, along with some of the standard and some of the over 65s. We've also recognized, as Mark pointed out, that there are some specialties that we just have inadequate material. This has been recognized, I think, in the trauma surgery community as an example. For a long time, we have C-STARS along with Ryder down in Miami and LA County to be able to help work that. Clearly, that's one model. We've been working with the VA as another model, and clearly there are other partnerships. So as you remember, one of Dr. Woodson's areas was partnerships, and this fits into this whole idea of being able to maintain our medical readiness. There are also, and this slide, which most of you probably can read, it's almost big enough, has a number of additional recommendations of things that we think as a system we need to do, like codifying the model to have it available to planners. When a service is recommending replacement of a hospital, we know an average hospital now is $500 million to $1 billion. We need to look at what does its sizing and demand need to be relative to the market. Maybe it needs to be bigger, because usually the recommendations are always for a bigger facility than what I presently have. It may be that it needs to be smaller, or maybe it should become an ambulatory care facility with a robust, maybe a birthing center and an ambulatory care surgery center. And so incorporating it into our planning processes. And then a number of other recommendations that we probably ought to really get to questions, because I think there are probably plenty with the provocative information we talked about. But I will say, and the services and all the team members have been incredibly supportive of this, and I do genuinely think that the group has come up with a very valuable set of tools that we've not had in the past to look at the entire MHS from an enterprise perspective, to be able to be sure that we maintain this incredibly valuable capability for producing a ready medical force and a force that's medically ready. So with that, let's open it up to questions. All right, Pat, I think you're up first.
Interesting to look at all this and see how you came to it. I'm just interested, do you think you're going to be getting political pushback? In some cases, and how will you deal with that? Obviously, you thought about it.
Whenever you do change, there's always going to be those that do not see it as a positive thing. And we recognize that, and part of it has been an outreach that we've been doing to the various constituencies. The services have been actively involved in it. There's a fair amount of outreach within our own department that we have been working through. But yes, we fully anticipate that. And I will say that now that the NDAA is out, there's a whole section on the modernization study and requirements of review by the GAO and other details, if you will, that we have to do to further the analysis on the behalf of Congress. So the answer to your question is clearly yes. There are a lot of political issues that we will address. Mark, do you want to?
Well, yeah, just to sort of put a point on that, you know, everybody knows that we have come up with some recommendations that are location specific, right? But again, I think it's important to understand that this study was informed by what we knew about the situations as we developed our recommendations on a facility basis using the model. But at the end of the day, and we go through execution, if something has changed or something that we thought we understood was not exactly right, then we're going to have to be flexible in dealing with that. And I think that's where part of the angst is potentially in some of the politics, is that this is a done deal, kind of like BRAC, and you got to go do it. It's not quite like that, because this is not BRAC. This is us taking a look at ourselves, through the lens of what is the best way for us to maintain our readiness position as the world's leader in what we do, and demonstrated that for 12 years. That's what this is about. And so we're going to continue to go down that. I believe, and I've said this before and I'll say it in public, this is one of the best justifications for the direct care system that I've seen in 35 years of doing this. And I stand by that.
I got an additional comment on that. And also, not because I'm wearing a blue uniform right now, but I do remember, in fact, there's a former Surgeon General in the audience that could probably expound on this, but the Air Force went through this about 15 years ago, 15, 20 years ago. Because of the way the Air Force is organized, trained, and equipped, we're about the same size as the Navy, but we're dispersed across the globe in smaller increments. And so, we have more bases, but we had smaller populations. So because medicine was changed, it affected the Air Force to a larger extent sooner than it did the other two services, because most of our hospitals were what we would call small community hospitals, which was the standard of care when we were growing up as kids. Everybody remembered a 10-bed community hospital. No such thing anymore. And so medicine changed, the Air Force. So it can be done. They, in fact, I would bet General Radebush there probably was action officer on many of these, if not a senior leader by that time, probably got the scars to prove it. But they worked it through the resistance both on the line level and also on the hill level, because at the end of the day, it was hard not to follow the exact same reasons that we were driving this modernization study. What right looked like were the same principles back then. I don't know, Dr. Radebush, if you wanted to expound on that at all.
No, actually, the ability to work that, it's certainly with our line leadership, because the Air Force tends to fight from our bases. We don't deploy forward to do that. Quite often, we'll provide strategic deterrence from Cheyenne, Wyoming. It's not the Army model, it's not the Navy model necessarily, it's the Air Force model. So the equities and the details of how best to do that and preserve both medical capabilities as well as support of the force and the families was a challenge. And there was political pushback, but the rationale was compelling. So I think the rationale for this is equally compelling. Not in my district is a reality. So we live with that. But I think if you go in with the homework done, the rationale intact and compelling, then I think you can make the case. And I applaud the analysis. I didn't hear initially if the underlying assumptions had to do with force mix, active guard and reserve, or if that'll be a derivative discussion as a result of this, where we might better position some of these folks if they're not, if we're not able to keep them active and productive in the regular component, would they be better placed into the guard or the reserve? That may be a derivative discussion, as well as do we put active forces into civilian brick and mortar, where that makes sense. If we don't have to buy that $500 million hospital, my old line was, I'm a Hertz guy, I don't have to own it to drive it.
Right.
If I can put active duty providers into civilian brick and mortar, leverage their capacity but still accomplish our mission, that's okay too. So I don't know if that was a piece of that. So my apologies for taking a few seconds more on that.
No, that was great, because those are going to be subsequent. They're in the recommendations as part of the way that we deal with this issue of the mismatch between the population and our capacity. ACRC mix is clearly a critical piece of that, as is looking at other practice opportunities. So, other questions? So, yes, ma'am.
When you were talking about the total authorized force, did that look at other than physicians? So that seemed to be primarily a physician
Yes.
model.
Yeah, absolutely. And what I tried to say early on was this model is very provider-centric, But the assumption, which, you know, there's clearly always interesting elements of assumptions, is that if I've got a situation where that provider is really quite productive in maintaining his or her readiness, then the team that supports them will also. But the numbers that we calculated as far as what the requirement is for the force includes all uniformed medical department personnel. Yes, ma'am.
Sir, thank you. That was sort of my question as well, is the ACRC mix, not only coverage of the population itself, but maybe particular models that could be looked at for coverage, not exactly parity, but necessary for that particular population.
I'm not sure I understand the coverage piece. I will tell you that we clearly have started looking into the ACRC piece, and it raises questions. If I have what clearly looks like a large number of a specialty that may be more than what I need on active duty, and or I've got plenty of capacity to keep them active on active duty, why do I also then have a substantial amount of that specialty in the reserves? Vice versa, if I have a really hard time maintaining something because of the configuration of the direct care system, can I attract them to the reserves and maintain them, which is, all these are clearly service questions that need to be looked at. We're just sort of shining bright lights on things to examine, but that may be a very reasonable solution. So I hope that answered your question. Good.
All right, time for one more question.
Okay, who gets it? Sir.
Dr. Mack, pediatric producers, what I didn't see in there is the utilization rate. How did that play a role in determining the manning of various facilities? For example, while I know that the outpatients utilize our services much more than my civilian counterparts.
Great question. And that was clearly is in the model. And we based the utilization rate on what the utilization rate was or is for the particular area that we were examining. So as our prevention efforts, our emphasis on health ideally changes that rate, then the model can accommodate that, because we're part of our second review was to take the next year's data and put it in and rerun the model. And the model is quite flexible to be able to do that. So we're a little agnostic to the utilization rate on this model, but clearly it makes a big difference as to how productive and how much material, if you will, there is for the providers. So thank you all very much.